When did someone challenge you at something you were an expert at? I was the most experienced nurse in the ICU with 17 years under my belt when a new medical intern tried to override my patient assessment. It almost cost a young mother her life. We had a 26-year-old patient, Melissa, admitted after a routine C-section. Something wasn't right. Her vitals were stable, but I noticed subtle changes in her skin color and breathing pattern. Classic signs of internal bleeding that wouldn't show up on standard monitors yet. I paged Dr. Parker, the attending physician I'd worked with for years, but instead, this new intern, Dr. Foster, showed up, fresh out of med school with perfectly pressed scrubs and a superiority complex. I explained my concerns, and he immediately dismissed them. The monitors show she's fine. Her charts indicate normal recovery, he said, barely looking at the patient. Then he had the nerve to add, "This is why nurses shouldn't try to diagnose. You're causing unnecessary alarm." My face flushed hot. 17 years of experience reduced to unnecessary alarm by someone who'd probably never seen hemorrhagic shock except in a textbook. With all due respect, I said, keeping my voice steady, I've seen these exact symptoms progress to hemorrhagic shock dozens of times. We need to get her back to surgery now. Foster rolled his eyes and wrote anxiety management on her chart. "Maybe you should take a break," he said with a condescending smile. "I'll order a mild sedative." I watched him writing the order, medication that would mask her symptoms further, and my hands shook with anger. Melissa's husband stood in the corner, clutching a stuffed bear for their newborn son, eyes darting between us. As Foster was leaving, Melissa's blood pressure suddenly dropped. Not drastically, just enough that an inexperienced provider might attribute to medication, but combined with her other symptoms, it confirmed my suspicions. "Dr. Foster," I called after him, pointing to the monitor. "Her pressure's dropping." He glanced at it dismissively. "It's within normal limits. Stop catastrophizing." Foster refused to call in the surgical team. "We'll monitor and reassess in an hour," he said, and walked out. I stood there, heart pounding, knowing that in an hour, Melissa might be in irreversible shock. In that moment, I made a decision that could cost me my job. I immediately called Dr. Parker directly on his cell, bypassing protocol entirely. "Karen, everything okay?" Parker answered, concern in his voice. I never called him directly. "No," I said, my voice cracking. "Room 4216. Post C-section with suspected internal bleeding. Foster won't listen." "On my way," he said without hesitation. Those 5 minutes waiting were the longest of my career. I watched Melissa's breathing grow more shallow, praying I hadn't waited too long. Parker arrived, took one look at Melissa, and rushed her to surgery. The relief I felt was overwhelming, tears pricking at my eyes as they wheeled her out. They found a slow arterial bleed from her C-section, the kind that builds gradually until it's catastrophic. During surgery, Dr. Parker discovered she'd lost nearly 40% of her blood volume already. When Foster found out, he filed a complaint against me for insubordination and overstepping nursing boundaries. He claimed I had undermined his authority and created confusion in the treatment plan. The hospital investigated, pulling all the records and timestamps. The surgical team confirmed Melissa would have died if we'd waited even 30 more minutes. Foster's complaint backfired spectacularly. 3 weeks later, Foster was transferred to dermatology. Melissa recovered fully, and later sent me a photo of her holding her baby for the first time, still pinned to our break room bulletin board as a reminder to always trust your experience.